Hi guys, today we will see about the physiological jaundice. Okay, what is physiological jaundice? Now the topic is physiological jaundice. Okay, now what is physiological jaundice? It means the jaundice that is due to the physiological, not due to the pathological condition. Okay, like it is the normal physiology of the body when there is a alteration, not alteration, there is a normal physiology, but by that normal physiology there is a cause that jaundice that is known as physiological jaundice. Later we will discuss here how the physiological functions can cause the physiological jaundice. It is very common we seen in the neonates. Okay, that is very commonly seen in the neonates. Okay, now the physiological jaundice, we already know the definition and causes and all these things. Now causes we don't know, we know, but we can find right here. Okay, before going to the in detail about the physiological jaundice, I have to show you that how is the normal uh, physiology that works in our body, like the excretion of bilirubin from the body, how bilirubin is produced and from where it is produced, all these things. Okay, see this, let me discuss here that the normal physiology of the uh, bilirubin excretion, production and all these things. Okay, now let's suppose here it is your a big macrophage, a big macrophage, a big macrophage that is present in the what endothelial system. Okay, okay, yes, now it is a macrophage. Here RBCs are there. Okay, RBCs, the RBCs here they break down in, one is heme, another is globin. Okay, this globin is amino acid converted into amino acids and it is useful to our body. Next is heme is converted to two compounds. That one is biliverdin, another is iron. Okay, iron. This iron is goes to the bone marrow. Bone marrow helps in the erythropoiesis. Okay, erythropoiesis. Now this biliverdin is reduced to a compound called bilirubin. Okay, bilirubin. Here is a special enzyme which is known as bilirubin reductase. Okay, this is known as bilirubin reductase. Now here heme is converted to biliverdin and iron by the enzyme called heme oxygenase. Heme oxygenase. This enzyme that converts biliverdin heme into biliverdin and iron. Iron is combined with the plasma protein, that is apoprotein, and this apoprotein is goes to the bone marrows and helps in the erythropoiesis. Okay, next this bilirubin. Now let me draw here circulatory system. Okay, this is our central circulation. Okay, these are the capillaries which are coming from the spleen. Okay, it is a big macrophage. Hypothetically, this bilirubin comes in this circulation. Now this bilirubin is unconjugated, unconjugated bilirubin, unconjugated bilirubin, which is come in the central circulation. From this here, the bilirubin is come in the central circulation. Now here is a special structure that is called, okay, it is a special structure. Here it is known as liver. Okay, liver. From liver there is a production of, let me draw here capillaries which are coming to the liver. Okay, yes, now this is the capillary or blood vessels that is coming from the liver. Okay, now from liver there is a special enzyme which is produced from the liver, that is called what, bilirubin binding protein. Okay, bilirubin binding protein. This bilirubin binding protein bind with this unconjugated bilirubin. Okay, now this unconjugated bilirubin is bind by this binding bilirubin binding protein. Now this unconjugated bilirubin is more soluble in this hepatocyte. Okay, the main reason of this bilirubin binding protein is to make this unconjugated bilirubin to more soluble in the hepatocytes. Okay, this is the main reason of bilirubin binding protein. Now this bilirubin binding protein is bind with this unconjugated bilirubin. Now this bilirubin is what? Soluble in hepatocyte. Let me draw here. There are two hepatocytes here. There are two hepatocytes. There are many hepatocytes, but hypothetically you see it is there are two hepatocytes. Now this unconjugated bilirubin come in this here structure. Now there is a structure that is present, or the receptor we can say here, that is present in the liver hepatocytes, one side of the hepatocyte, that is called sinusoidal or sinusoidal phase of the hepatocytes. Okay, sinusoidal phase of the hepatocytes has a special receptor to bind this unconjugated bilirubin, bind with this plasma protein. This is bind in this receptor. Okay, that is bind in this receptor, unconjugated bilirubin. It is bind. Now this receptor uptakes this unconjugated bilirubin into the hepatocytes. Now this unconjugated bilirubin come in the hepatocytes. Okay, comes in the hepatocyte. Next, here it is a special enzyme that converts the unconjugated bilirubin to conjugated bilirubin. Unconjugated bilirubin is converted to conjugated bilirubin by the special enzyme that is called GT, that is glucuronide transferase. Okay, what is the enzyme here? Glucuronide transferase. This enzyme that converts the unconjugated bilirubins to conjugated bilirubin. Now here, okay, let me go here. Okay, these are the right hand from left hand, right hepatic duct that combine with the, okay, it is a cystic duct and that forms the common bile duct, and from common bile duct, okay, let me draw here, it is your stomach. It is our stomach. Now it is a C-shaped structure that is called duodenum. Okay, it is called duodenum, and this it is hepatic duct, cystic duct combined to form a common hepatic duct or bile duct. This bile duct or joins here in the another structure that is called, it is called ampulla of Witter. Ampulla of Witter. Here is a structure that is pancreatic duct is joined with this bile duct. It is called what? Ampulla of Witter. Ampulla of Witter is open in the duodenum by the sphincter called sphincter of Oddi. Okay, this is the sphincter called sphincter of Oddi. Now this conjugated bilirubin is taken up by this biliary duct, and from this the conjugated bilirubin come here from this biliary hepatobiliary duct, conjugated bilirubin, and that is stored here and come here, that is come in the intestine. Okay, comes in the intestine, that is conjugated bilirubin. Here it is. Let me draw here. It is not correct diagram. According to rule, there is come here. From this here, there is large intestine, but I draw here. Okay. Now this here conjugated bilirubin come in the intestine. Here in the physiological jaundice, let concentrate here. That is in the physiological jaundice. Here some bacteria are there. Bacterias, and those bacteria that convert conjugated bilirubins to two form. One is urobilinogen, another is stercobilinogen. Okay, one is stercobilinogen, another is urobilinogen. Okay, urobilinogen. Now another thing is this stercobilinogen is come here, and that is stercobilinogen is a brownish color that oxidizes with air, and that appear come in the fecal matter. That fecal matter appears as a brown color. Now this urobilinogen is taken up by this portal vein. Okay, these are the portal vein that is originated from the where? It is originated from the intestine. From intestine, these are the portal veins. These portal veins come from the liver and through the directly lead into the central circulation. Okay, central circulation. From central circulation, now this urobilinogen is come here. This urobilinogen is come here. Urobilinogen come here. This urobilinogen, and this come in the central circulation. Next, here is an important structure that is called, okay, kidney. From in kidney there is a renal supply. From here there is a renal supply. from renal supply, this urobilinogen come in the kidney, urobilinogen, and it is not soluble in the water, so that this urobilinogen come in the urine and appear as a yellow coloration, yellow discoloration of the urine. That is due to the urobilinogen. Okay, that is due to the urobilinogen. Now this is our normal physiology of the how bilirubin is produced, from where it is produced, and how it is circulated in our circulatory system, from where what are the enzymes that bind with this unconjugated bilirubin to more soluble in hepatocytes, how it is taken up by the hepatocyte, and how the unconjugated bilirubin is converted to conjugated bilirubin by the important enzyme called, that is GT, glucuronide transferase. From this there is a hepatobiliary duct and lead into the small intestine, and that is small intestine, the bacteria that convert the unconjugated bilirubin to stercobilinogen and urobilinogen. The stercobilinogen come under the feces, and the urobilinogen goes to the again central circulation by the portal vein, from the portal vein, and from the portal vein the central circulation, the urobilinogen goes to the kidney. From the kidney there is a the urobilinogen excreted through the urine. Okay, this is our normal physiology. Now what are the physiological changes in neonates? Okay, here let me know here. Okay, yes, sorry, yes, series. Now first condition in the neonate is, first condition is deficiency of GT. Okay, in neonates the liver is not mature, that is liver is immature. This enzyme is deficient here. Okay, by this enzyme the unconjugated bilirubin is taken. Okay, that is in the hepatocyte, but this unconjugated bilirubin is not converted to conjugated because there is a deficiency of glucuronide transferase. This is present, but the amount is very less. Okay, that's why there is a physiological jaundice. This is a normal physiology, but the physiology is very slow. By that there is a jaundice occur. That is, and here in the if there is a decrease or there is a deficiency in the glucuronide transferase, the transferase enzyme, which type of hyperbilirubinemia is there? That is unconjugated hyperbilirubinemia. Okay, this is a physiological jaundice. There is hyperbilirubinemia. Next, there is a deficiency of GT, and another is rapid hemolysis of RBC, or rapid hemolysis. Okay, here there is a RBC ruptures in 90 days, but in neonates the RBCs ruptures in only 90 days, because the normal breakdown of RBCs after 120 days in adult, but in neonates the breakdown of RBC is very fast. That's why there is an increased production of heme, and increased production of heme that converts the biliverdin, and biliverdin is goes to bilirubin, and excessive bilirubin is there, and the bilirubin workload is more on the liver. Okay, this is one of the cause of physiological jaundice in neonates. Next, another that is interesting, third is breast milk jaundice. Okay, breast milk jaundice. Now you can tell me that what is a breast milk jaundice here, and how it is cause the physiological jaundice. Okay, let me know in our comment section. Okay, now this is our normal physiology, and these are the physiological jaundice. Okay, these are the causes of physiological jaundice, you can say, and these are the types, you can say. Okay, because now this is our normal physiology. The problem may be in physiology, the problem may be here. It is not a problem. Okay, it is a physiology. Here it is one of the cause, and here it is one of the cause, deficiency of this enzyme, and next cause is breast milk jaundice, and where it is you can find it. Okay, if not, let me know in comment section, I will answer that. Okay, now this is clear about all these things. Now we can take a treatment modality, or going to treatment modality. There is a diagnostic evaluation. Okay, diagnostic evaluation. Now what is the diagnostic evaluation? See this. Okay, diagnosis. One we can take by physical examination. Physical examination. In physical examination, on inspection, there is ectodermitis. Ectodermitis. By this is a scale to measure the physiological jaundice. Okay, the jaundice which is present in the body. Now here some zones are there. Let's suppose here this is a fetus or neonate, not fetus, neonate. Okay, these are like all these things. Now here, if the discoloration, yellowish discoloration is on the face, where here some zone bilirubin level, bilirubin level in mg per dl, in mg per dl. Okay, this is our chart. Okay, here in zone 1, if there is a yellowish discoloration in the zone 1, it may be present 5 mg per dl. Not right here, 5 mg per dl, dl is already there, mg 5. Okay, next, if it is on the neck, if it is on the neck, there are 10. The score is 10. It means the bilirubin in the body is 10 mg per dl. Next, 3, that is in the abdomen or on the umbilicus, that is 3. Here, 15 mg per dl. Okay, 15 mg per dl. Here 4 on the legs, knees. Okay, knees, the legs 4. It is about 20 mg, 20. Next, 5th, and there is a 5th. There is on the lower toes. There is more than 25 mg per dl. These are the zones of the bilirubin levels. Okay, this is present in the blood. Now this is our dermis ectorus. Okay, now second physical diagnostic is second diagnostic evaluation is blood investigation. Blood investigation. In blood investigation, we see serum bilirubin. Serum bilirubin. It may be more than 5 mg per dl. 5 mg per dl. Next. Now this is second test. This is our diagnostic evaluation. Okay. Now, what are the treatment modalities? Now we discuss the treatment modalities. Okay, treatment modalities of physiological jaundice. Treatment modalities, it includes, one is pharmacological treatment. In pharmacological treatment, one is phenobarbiturate. Why this phenobarbiturate give here? Next, second is metallopyrrolate. Next, third is exchange of blood. Okay, exchange of blood, not it is blood transfusion, it is exchange of blood. These are the pharmacological treatment. Next, another is there important, that is phototherapy. Okay, this phototherapy, this is important. Okay, phototherapy. In phototherapy, we will discuss another video, and here let me tell you here, there is phenobarbiturate that increase the or promotes the increased synthesis of GT and BBT, that is bilirubin binding protein, and glucuronide transferase synthesis is done by this phenobarbiturate. Next, this methyloproparate that reduce the activities of heme oxygenase. It reduce activity of heme oxygenase. Next, exchange of blood is there, and phototherapy. Okay, this is phototherapy. This is all about our physiological jaundice. If any doubt is there, let me know in our comment section. Please like, share and subscribe. Thank you for watching.